Just a quick but really important note before we start. This is purely for educational purposes and isn't personal medical advice.
Okay, imagine this scene. You're in the ER, alarms are going off, and your patient's blood pressure is absolutely tanking. They're in shock, and in that moment, their survival hangs on a thread. You might think it's all about the heart or the blood vessels, but what if I told you the real key to saving them lies in understanding their kidneys?
So today, we're going to pull back the curtain and see how the kidneys become the body's ultimate first responders. These incredible organs are master regulators, and honestly, they can be the difference between life and death when someone's in shock.
So what's on the docket? Well, here's our roadmap. We're going to start with what the kidney actually does in a crisis. Then we'll zoom right in on the nephron, the tiny engine that makes it all happen. From there, it's all about the practical stuff, decoding labs, mastering fluids and assets, and then a super focused, high-yield review to get you prepped for exams. And of course, we'll wrap up with a little quiz to make sure you've got it locked in.
First up, the kidney in crisis. At its heart, shock is a perfusion problem, right? The organs just aren't getting enough blood. And when perfusion drops, the kidney is right there on the front lines.
Now, what's so fascinating is that in shock, the kidney plays this crazy dual role. On one hand, it's a victim. Its inner part, the medulla, is already running on fumes with low oxygen reserves, so it's super vulnerable to damage when blood flow drops. That's how you get an acute kidney injury, or AKI. But at the exact same time, it's a powerful compensator. It senses that pressure drop and immediately fights back. It cranks up the RAAS system to hang on to every bit of salt and water and slashes urine output to preserve volume. It's basically the patient and the doctor all at once.
So how in the world does it do all that?
Well, to get it,
We have to zoom in, way in, to the nephron. And we're going to use a really effective learning trick here. First, I'll give you a simple, everyday analogy, and then we'll dive into the nitty-gritty details you'll need for your exams.
So, let's start with the glomerulus. The easy way to think about it, it's like a super high-tech coffee filter for your blood. As blood flows through, all the small stuff like water, salts, and glucose gets through, but it's specifically designed to hold back the big important things like proteins and red blood cells. Simple as that. Okay, now for the exam-level stuff. That coffee filter is way more sophisticated than it sounds. It's actually a 3-layer barrier. You've got the fenestrated endothelium, the basement membrane, and these cells called podocytes. Together, they create what we call an ultrafiltrative plasma. But here's the bottom line, the thing you have to remember. If this filter gets damaged, big things like protein and blood start leaking through. So if you see that in the urine, that's your red flag. The filter is broken. Okay, so after the filter, all that fluid goes into the proximal convoluted tubule, the PCT. The analogy here? Think of it as the kidney's master recycling center. Its entire job is to just furiously grab back everything good that just got filtered out. We're talking water, salt, glucose, and get it back into the blood.
And now for the technical breakdown. If you look at these PCT cells under a microscope, they're just packed with mitochondria, little energy factories, and they have this dense brush border to create a huge surface area for reabsorption. They pull back about 2/3 of everything we want to keep. But here's the catch, and it's a big one. All that work takes a ton of oxygen. So when a patient is in shock and oxygen delivery drops, the PCT is one of the first things to get hit hard. That injury is called acute tubular necrosis, or ATN. So we get the structure. Now let's see how all this plays out in the lab work. It's time to turn those numbers into a real diagnosis.
So let's say a blood gas report comes back for your patient in shock. The pH is low, the bicarb is low. You know right away this is metabolic acidosis. But where do you go from there? What's the very first question you have to ask to figure out why?
The answer is all about the anion gap. This is your workflow every time. 1. Confirm the metabolic acidosis. 2. Calculate the anion gap. 3. Classify it. Is it high or is it normal? Just doing that one thing instantly slices your list of possible causes in half. And this table really shows you why that's so important. When you have a high anion gap metabolic acidosis, a HEGMA, it means an extra acid has been added to the system. In shock, that's almost always lactic acid. But with a normal anion gap acidosis, a NEGMA, the problem is that you've lost bicarbonate, like with severe diarrhea. So, for your patient in shock, you're expecting to find that high anion gap.
Which brings us right to our next topic, how the kidney basically runs the entire show when it comes to managing fluids, salt, and acid in the body.
You know, to really get fluid balance, you have to think of the kidney as having two separate master controls. First, there's the volume control knob. This is all about sodium, because as you know, water follows salt. The RAAS system is in charge here, and when it's out of whack, you see things like edema or dehydration. Then there's the concentration control knob. This one is all about free water, and it's controlled by ADH. Problems here mess with your sodium concentration, leading to hypernatremia or hypernatremia. Two different knobs for two different jobs. And in shock, that volume control system goes into complete overdrive. The trigger is simple: low blood pressure. The kidney responds by unleashing renin, which kicks off the whole RAAS cascade. The undisputed star of this show is angiotensin II. It's a powerhouse. It squeezes blood vessels to crank up the pressure, it screams at the adrenal glands to release aldosterone to save salt and water, and it tells your brain to release ADH and make you thirsty. The goal is brutal and simple: get the blood pressure back up, no matter what.
All right, let's shift gears. Time for a rapid-fire, high-yield review. If you're studying for exams, these are the facts you absolutely, positively have to know.
First up, a number to burn into your brain. 8 to 12. That's your normal anion gap. If you calculate it and the number is higher than 12 in a patient with acidosis, your brain should immediately start yelling hagma, and you need to go hunting for the cause, starting with lactate in anyone who's sick.
Next, your patient's creatinine is climbing. Is it a prerenal flow problem or an intrinsic kidney damage problem? The answer is in the urine. If it's prerenal, a healthy kidney is working hard to compensate, so it will desperately hang on to salt, giving you a low urine sodium. But if it's an intrinsic injury, like ATN, those damaged tubules can't do their job, so salt just spills out, giving you a high urine sodium. This is such a critical distinction because it completely changes how you manage the patient.
Okay, let's put it all together. Time for a final knowledge check with the tough clinical scenario.
So here's the puzzle. You've got a patient with severe heart failure. They're totally fluid overloaded, you can see the edema in their legs, but at the same time they have signs of poor perfusion, like cool peripheries and a climbing creatinine. So my question is, why on earth is their RAAS system, the body's salt and water saving system, firing on all cylinders? It seems like the very last thing they need.
And the answer is a concept that ties everything together: low, effective arterial blood volume. See, even though the patient is full of fluid, their weak heart just can't pump it around effectively. The kidney doesn't care about the total fluid in the body. It only cares about the blood flow it's personally receiving. It senses that low flow, interprets it as dehydration, and activates RAAS to save more fluid, which, tragically, just makes the whole situation in the edema even worse. It's a vicious cycle.
And this brings us to a final thought. There's an old saying in nephrology: the kidney is the historian of our blood pressure. It doesn't just react to what's happening this second. It remembers, it adapts, and over time, it writes the story of our body's circulation. Learning to read that story is how we manage our sickest patients.